Welcome in, everybody. Thanks for listening to another episode of the Strength for Your Purpose podcast. I'm your host, Dr. Phil Finemore, owner of WorkFitME Mobile Physical Therapy, and I am super excited about this episode today. This is my first time having more than two other people on besides myself. We got a little round table here going this evening with a few other professionals that I'm collaborating with on a really exciting program right now. So really excited to get this episode to you. I was just thinking about this, and I realized that Evan, you and I have done interviews before, but I don't think I've had you on the podcast yet. We've done stuff.
No, I think this is the first time.
Yeah, we've done stuff on social media. So Valerie is the only recurrent guest at this point. Valerie Feghali with Valerie Diane Nutrition. I'm also joined by Stephen Saylor, who is a PA for Coastal Maine Direct Care right here in Falmouth, Maine. And just down the road from him is Evan Amell, who you just heard of EA Fitness and Performance. So we're going to let everybody sort of introduce themselves here in just a second. But the reason we're all on here tonight is to share something really exciting with you all that we've collaborated on and started working on with some individuals. And that is a medically supervised, all-inclusive diabetes prevention program. So this was something Steve, Evan, and myself came together trying to figure out how could we all work together within our respective disciplines where there's decent amounts of overlap there and have a real impact in an area of people's health that is, we're just sort of missing some pieces here. Be a little more collaborative, so that people aren't getting kind of lost in the wind, so to speak, for certain conditions. And we bat around ideas for things like arthritis or back pain and things that we all see are very common in the people that we help. But Steve had an awesome idea to tackle diabetes, and the reason for that being type 2 diabetes is not only preventable, but also when you have it to a certain point, it is completely curable. So there was no real programming that he could find, or any of us could really find, that was sort of an all-encompassing, all-inclusive program that attacked areas of being medically supervised, having a nutrition component, having addressing pain, a component that addresses pain and dysfunction, which might be holding people back from exercise, and then having that exercise component too, to take them all the way through a program to drop those A1C numbers, their blood sugar levels, get them moving more, and actually give them an incredible foundation to not only get out of that diagnosis potentially, but also keep themselves there long term. So that's sort of the basis of the program here. So without further ado, let's start getting into this a little bit, everybody. So Steve, I want to kick it over to you. Talk a little bit more about what you were seeing that kind of led you to saying, hey, let's have this be the thing that we tackle, and how this sort of got off the ground from your end.
Sure. Thanks for the introduction, Phil. My name is Steve Saylor, and you can see, you can't do that, can you? Can you get that in there? Coastal Maine Direct Care.
Oh, the filter's kind of funny. And we'll make sure everybody's information is in the notes of the show, so people will be able to contact anybody.
So we have a direct primary care clinic over in Falmouth, and you should look us up if you're interested in learning more about it. But one of the primary drivers of healthcare in the country, to be honest, is type 2 diabetes, and it's a serious plague on the country. Most of my day in primary care practice, high volume practices, is built around treating people's diabetes. And my background, I've been doing this for 27 years, so I've been doing this for quite a while. And prior to this, I was a personal trainer and was a competitive bodybuilder. And a frustrating thing when you get into PA school or medical school is the lack of really kind of bearing down on the role of diet and exercise in preventing most of the diseases that we treat. Okay, with diabetes being one of the leading ones. We give short shrift to food intake and its role in diabetes. And to be perfectly honest, I mean, when I first started in medicine, I was shocked to find out some of the things that the American Dietetic Association, our federal government's food guides would give us on how to eat, and it was preposterous, right? So most of it was based on high carbohydrate, intakes, we became, basically a glucose disposal machine for our industrialized farming communities. I mean, that's basically what they were pushing, is some way to eat all of these wheat products and corn products and, high fructose corn syrup. So when I got to college, I was shocked to see, or got to PA school, I was shocked to see, diabetic educators encouraging people to eat more carbohydrates. And that happened more frequently than I would have thought was reasonable, right? I mean, you would just try to break it down and say, listen, the problem is carbohydrates. The problem is sugars. The problem is the overeating of these things and the lack of exercise. And so I would spend an inordinate amount of time in the office trying to explain in the brief 15 minutes that you have with these patients and how you're scheduled, to break down for them the basics of, food intake, the, macronutrients, carbohydrates, fats, proteins, and how much of these you're supposed to eat. And, you would think most people really understand how to eat healthy. And I think most people do, but they just don't want to admit it. They don't really want to see, and make that change, because it's hard. And Val can attest to that. It's a behavioral issues that you really have to change, and it's difficult. And you have hormonal regulation issues that you have to deal with, and insulin, and and some people have just gotten themselves to this poor state of their physical health where they don't exercise enough and they overeat all the time and just don't see any way to get out of it.
Right. Hard to break that cycle.
And then once they get started on a lot of these medications, it's really hard to get them back off it and to change their lifestyle. So and I would have, every so often, I would get a patient in there, usually more of like an engineer type, or, someone who's has a little bit more time on their hands. And I would tell them, I'm like, listen, we can cure your diabetes. You're newly diagnosed. I guarantee it. If you follow my program here, well, I'm going to tell you exactly what you need to eat and how much to exercise. And here's how I would break it down. And because I only had 15 minutes, right? I only had a very short window of time to talk with these patients. Said, okay, here's what you can do. You can eat some eggs for breakfast. You can't drink anything with calories in it. You can have a big salad for lunch with about 6 ounces of grilled meat, whatever you want to have on it. And then you eat the same salad, big giant garden salad with some grilled meat on it for dinner. And you just keep repeating that diet every day for the next 3 months. And then you need to get about 500 to 600 calories of exercise in a day. I don't care if you walk, run, or go to the gym and lift, but you should do some weightlifting. You should do some cardio most days of the week. And by the time you come in at the end of 12 weeks, I almost guarantee you that your blood sugar is going to be normalized. And the people who did it, they would come back in with basically a normalized blood sugar. But those are rare people. I would say if I had 100 people in my clinic, maybe 10% of them would do it.
Right.
You try to break down what carbohydrates are and what fats are. And my wife, who's a physician, told me this great story where she was discussing her patient's diet and explaining, you really need to stop eating so many carbohydrates. And this patient looked at her and said, how about cheese puffs? Because they're mostly air and cheese. So is that kind of bad? And all you can do at that point is just hand over the diabetes medication and ask them to come back in 6 months and check it out. But, when you guys and I all sat down, Evan and you, we were talking about like what would make some of the biggest impacts. What could we do to make a big impact? And diabetes is one of them, right? Yeah. And the challenge with being a medical provider is like, I was formerly a trainer. I could probably train them too, but there's only so much time you have in your day to do everything. Right. So, we met Evan. I was like, here we have a personal trainer. Too bad, we don't know a dietitian nutritionist. And Phil brought along Valerie and Phil brings in, the musculoskeletal component for injury. Cause a lot of people, will make excuses for not exercising. People will say, oh, my knee, I can't do it. Oh, my back or my neck, or my hip or something. But if you can move, there's always something you can do physically. There's always some kind of way to burn calories and to keep moving and improve your physical health. And, a lot of times movement hurts for people when they get to middle age and older. But, like osteoarthritis, it hurts if you move it, but the problem gets worse if you don't.
Right. And I think that's the big thing here with this program is all of us operate in a way that is much more conducive to not having a 15-minute appointment and trying to cram as much information with that person in as possible. And we're able to, all within our own respective areas of expertise, and where those areas of expertise overlap, spend the time with that person getting down to the true root cause of the problem. That isn't always just the blood sugars are high, they don't know how to eat right, they don't know how to exercise, and we can tease all those things out and help them along in that. So that's that's how we're really trying to change the narrative here a little bit that you used to see earlier on in your career, I think.
Yeah, like our first client that we had, he was one of those guys who, if I was working in a different style of practice in a, regular corporate hospital owned family practice, he would still be stuck in the same routine of me trying to, manage his blood sugar with medications and give him some encouragement to hit the gym and start exercising. And,
Sure.
it would just be this constant battle of trying to drive down his blood sugar. But with the way our practice is designed, I sit down with him for like an hour and a half, and I could figure out like, oh, he's, there's stress with his kids and there's family issues. And then he's also, putting in like 80 hours of work a week. So, there's a lot of other things that you need to take into consideration other than just exactly what the numbers are, like, are we achieving the goal of his, hemoglobin A1C? Are we achieving the goal of his LDL level? So there's a lot of other, social factors you need to take into consideration, and to be honest, psychological factors. A lot of people that I see, sometimes you just have to put them on, antidepressants because they just can't make it out of bed. They just can't get motivated and feel hopeless and helpless. And so sometimes you have to, augment that with, other medications and take into consideration their psychosocial state.
Sure. No, and that's a real big component. You mentioned perfectly how Valerie came into the fold on the program here, not just counseling on the nutrition in a very well-rounded way, but also attacking some of what you just mentioned, some of those more
behavior,
emotional, behavior, psychological connections to the food. So I want to shift over to Valerie here real quick and have her talk a little bit about what she's doing on that front within the program, because that is that when we all kind of put our heads together on this, that was the big thing, is the guidance, support, and accountability that we're all giving within our areas of expertise. So Valerie, please take it away and tell us a little bit about what you're doing within our program here. Oh, you're muted still, Valerie.
Muted.
Muted. Hey guys. So thanks, Phil. So so basically what I'm doing is coaching on nutrition and wellness, and basically teaching people how to develop better habits. That's the biggest thing. How can you develop a routine and a habit that's consistent day to day, that's easy for you to follow through with, and that's not this thing that becomes this effort and this added stressor to your life. This topic is really near and dear to me. It's something that I think a lot of people don't realize is as important as it is. They actually did a recent study where they followed, how many people, I had written it down, but 8,721 people in this study. And they found that only 12% of those people were metabolically fit. These are average American adults.
Wow.
And so if you sit in a room with 15 people, maybe 2 of them are metabolically fit. And these are the average people that you're hanging out with, that you're sitting around, right? And so this is really a huge problem in our society. And I think it's becoming more and more to light, especially with the pandemic and everything. People are realizing how important preventative medicine is, and how important, being fit and healthy to begin with is for your health. So, one thing, my role in this group really is to support, educate, and provide the necessary tools that people actually need to adjust their diet and self-care routine in a way that actually works for their lifestyle. I hope if there's one thing that we've all recognized as a society, is that simply suggesting that we eat better doesn't work, right? Because people, number one, don't really know what that means. And number two, are unable to follow through with it because of the emotional connection they have with food. So nutrition and psychology, right? They're really complicated. A lot of people think it's simple, and it's not. I'll give you an example. So let's just kind of talk about what happens in the brain when we eat something that's either sweet or savory. So we get this dopamine hit, right? And it activates the pleasure centers in our brain. And it says, wow, that was really great, right? So this response is increased exponentially when we have something that's hyper palatable. So a lollipop compared to an apple, you are going to get a lot more of those sensory receptors responding to that lollipop. What happens is we then become desensitized to that. So much of it is going on that we become resistant to that phenomenon. So we get less receptors and less receptor activity, even when we're eating that same amount of sweet. So that affects not only our pleasure centers for food and increases our cravings and our feelings of need for carbohydrate, but it also affects our ability to enjoy other day-to-day activities. So, Steve, you talked a lot about these people feeling depressed, these patients or clients feeling depressed. And it's not just situational, it's actual physiological depression, right? That they are not getting enough of those dopamine receptors in their brain to hit when they're doing stuff like, socializing with their friends, being with their kids, performing a sport that they love, intercourse. There's so much, right? That is no longer as enjoyable as it once was because their brain chemistry has changed.
Yeah.
And so it's a huge obstacle for people to change their diet, because the only thing that makes those receptors really fire at that level is candy and those really, refined sugars and carbohydrates.
So good.
So it's tough, right? And that's when people have that urge to indulge.
Yeah.
So, in addition to that, and on a more, straightforward level, is that people just don't really know at this point what good nutrition is. We have so much crap that is on the shelves right now that's filled with heavy metals, that's filled with, emulsifiers that have carcinogens in them, so much junk that goes into our foods, and people don't know how to sift through what is actually beneficial for them. People go to the health food store and they buy something that says like, good for brain health or good for heart health or whatever. They pick it up. It's filled with industrial seed oils. It's filled with emulsifiers. It's filled with all these chemical preservatives that have a huge impact on our physiology. So I help people by giving them the tools that they actually need, shopping lists, meal plans, that type of thing that helps them actually say, okay, I know that, Valerie kind of approved this for me, and this is exactly what I'm going to look for. This is the brand I'm going to get, and start going from there, so that they actually have a plan to follow through with, and not just going blindly to the store thinking I need to eat healthy. This says low carb. This says gluten-free, because those things can often be a lot worse for our health than just the regular product that's not gluten-free, perhaps.
Sure.
Not that I'm condoning gluten, right?
Right.
But what I'm saying is marketing scams are really tricky.
Big thing.
Really, really tricky. Yeah.
Cheese puffs are gluten-free, right, Steve? Is that...
I'm sure
I think so.
I'm sure they make them gluten-free. But what's in it? Soybean oil, and that will kill you.
Sure.
So so this issue of hyperglycemia and insulin resistance can cause so many things, from heart disease, cardiovascular issues, which is Alzheimer's even is linked to it. PCOS, so many infertile women at this point that are dealing with this issue, erectile dysfunction, and then also just the things that people might recognize, and not be diagnosed with, but brain fog, fatigue, lack of energy, all that stuff is associated with insulin resistance. And, we could say caused by insulin resistance, I think, at this point.
That's a good point.
So sorry to take up so much of this time.
No, that's great. No, it's fantastic. I think that's a lot of what you said is exactly the point. My mind, as you were talking about giving people the tools, goes back to the fact that even if people tried to take an initiative of this and did like a simple Google search, I would charge anyone listening right now to go Google how to eat healthy and try to sift through and make any sense of that information on your own if you have no background in it, right? If you're someone who doesn't know the things that Valerie knows. It's
Yeah.
almost impossible. You know, I warn people all the time. I'm sure Steve and Evan, you do too. Dr. Google probably doesn't have the answer for a lot of these things we're helping people with, or it might be out there, but you're not going to know which one it is because you're going to be inundated with all this information. So
it gets worse than that. I mean, like,
Yeah.
I don't know, did you guys watch that Netflix series? What was it where they were trying to explain how bad eggs were for you, or, you know, like eating an egg was like equivalent to smoking a cigarette? What was the name of that show on Netflix?
Oh,
Do you remember what I'm talking about?
think
Like
I do.
everybody
No,
was
I know what you're
talking
talking
about
about. Try a couple of the name, but I don't know what you're talking about.
Yeah.
I'm trying.
I can't remember the name of it, but like I spent an inordinate amount of time.
Was it What the Health?
That was it. That's it.
There we go.
Yeah. I spent an inordinate amount of time trying to explain to people like how it was basically wrong. They were trying to say how animal fats increase your blood sugar more than carbohydrates do.
Right.
And I was like, it doesn't sound right.
Yeah. And the thing is, a lot of these studies that people are referring to with animal protein being bad, the studies are conventional animal protein, right? If we look at conventional carbohydrates and compare the two, that's a real problem. But yes, I mean, chicken that is not fed its natural diet and has no circadian rhythm close to its natural, it's bad for you. Just like, you know, if a person who's eating Skittles all day, they're not going to have good meat quality, right? It's the same thing. And so you compare the omega-3 to omega-6 ratio in a grass-fed burger versus a, you know, grain-fed burger, there's a dramatic difference. And that's another thing that, you know, I coach and educate people on is quality really matters. Quality really, really matters. And then there's other strategies too. Timing of when people eat, sleep, the quality of people's sleep. Guess what cortisol does? Cortisol levels rise when you don't get good sleep, and blood sugar levels rise when cortisol is high. So there are so many different things and ways that people can tackle their health. You just have to find the lowest hanging fruit and start there and work your way up.
Baby steps. Someone I talk with and work with a lot loves to give the analogy of two 100-foot ladders side by side, and one ladder, the rungs are like a foot apart. And then on the other ladder, the rungs are 10 feet apart. So by the time the person going up the ladder with the close together rungs, they're 2/3 of the way up, and the first person is still trying to figure out how to get to the first rung. Right. So like you said, that low hanging fruit, those baby steps are incredibly important. And sometimes we need some help finding those baby steps. Cause like I said, it's so easy to watch a Netflix docuseries and you think, well, Netflix wouldn't put anything on there that's going to mislead me. But I actually heard an interview on a podcast recently of the CEO of Netflix. I mean, they just make decisions based on how many subscriptions they think they're going to maintain and hold on to or gain from putting something on there. You know, they don't necessarily care if it's 100% factual. You know, that's up to the consumer to figure out. That's not on them. So yeah, it's great to have some of that accountability, that help, that guidance and support to going on those baby steps to start making that.
And I think the nutritional and dietary industry is just fraught with so much fraud.
Yeah, it's a hard industry to make sense of because there's so many confounding variables, right? Like there are certain things we know for sure, and that's what I know, Valerie. That's what you base your programming on, is the things we do know for sure. But yeah, it's tough because it does change a lot more than some of the things that like myself, Steve, or Evan does, just because again, there's so many variables that are so hard to control for when it's being studied. But that's all medical jargon that we're about to get. That's a whole other conversation the four of us could have and go down the rabbit hole on. But no, I think that's the like you said, Valerie, the low hanging fruit. What are the smallest steps that make the most sense that we can change and make right now that aren't going to feel too drastic, aren't going to feel too out of reach, and give you the tools to make this change happen moving forward. Right. That's the big thing. And
people to feel.
Sorry, go ahead.
We want people to feel, you know, in control and successful right off the bat and not be defeated. Because if you give too many challenging goals right away, then it, you know, change is hard. Change is really hard. And we have to move at it slowly. And then the habits start to form. And once the habit is formed, it snowballs from there.
Yeah, 100%. And I think I think taking steps is a perfect segue to send this over to Evan Amell of EA Fitness and Performance. So Evan, talk to us a little bit about how you approach what you do and how that approach is helping support people that are in this diabetes prevention program.
Yeah. Hey guys. Yeah. So thanks for having me here. Yeah. So my name is Evan Amell from EA Fitness and Performance. Have my own personal training studio in Falmouth. We offer personal training, small group personal training, online coaching, and nutrition coaching. But that's not my role here. My role is exercise. So yeah. So my role in this program is I'll be taking each person and introducing the exercise. And it sounds simple, but it's actually really hard, especially with people that are pre-diabetic or have kind of like other conditions, because, I understand that, some people don't have the experience of working out, and the thought of doing it on their own is, very intimidating because, well, one, they think that they're going to be judged if they go commercial gym and work out on their own. And they don't even know where to start. So they don't even bother, and they make excuses of like, oh, well, I got this, I'm too busy here, I got this ache, and they just continue to make excuses, when in reality, taking that first step is really what they're really nervous about. And that's where I come in. And I try to make this transition of adding exercise in their life, make it as easy and as comfortable as possible. Because for me, I will completely personalize the exercise program based on where they're at. And, in this case, where we're working with somebody that we'll probably talk about a little bit later, working with Dr. Phil and just kind of complimenting some of the stuff that he's doing with them. Because ultimately my goal is like, I'll be working with them on the exercise part, but then also like down the road, like, it's part for injury prevention as well. Because we know strength training is a big component in injury prevention, especially as we get older, and it gets more important even outside of having pre-diabetes. So ultimately, we really know that, everyone should be really moving daily. And I would just want to give the opportunity for, in this case, somebody that's pre-diabetic, that extra support in place, so they can have a chance to make a real difference through fitness. And I'm just really excited to be a part of this special program to hopefully prevent and potentially cure type 2 diabetes.
Yeah, that's fantastic. And the other thing that's great about what you do, Evan, is talk a little bit about the assessment you use to onboard people and help to personalize their program, because that gives you a lot of information. Well, me as well, because we're able to talk about what that assessment looked like and see what that person's going to need from potentially a pain relief standpoint, to help make that exercise that much more effective than it already is for that person. So talk a little bit about that.
Yeah. So basically, when I'm taking on a new client, so we start off with the in-body scan, which if nobody's on that's listening has ever heard of what in-body scan is basically, it basically tells you what your muscle mass is at, your fat mass. It tells you your metabolic rate based on bioelectrical impedance. So depending on how quickly the electrical currents that it sends through your body, it will tell you all those statistics, which actually can be helpful for Valerie as well when she's doing nutrition. But for the exercise part, it actually tells me, right off the beginning, like, how their muscles actually distributed, and like how much, because a lot of the time, so like when we're going over the segmental lean analysis on the in-body scan, where it tells you how much muscle mass you have in each limb. So like if I see that, they're below 100% in their lower body, that means that like, doing just body weight exercise is more than enough, because that basically means that they don't have sufficient muscle mass based on their height, their age, and their overall body weight. So, that's kind of part one of the assessment. I could talk forever about that. But after that, we do a functional movement screen, in which that we are able to just take them through simple foundational movements that every human should be able to move through, and identify some of maybe the weak areas that they might need to work on, see their strengths. So then, when I'm creating this exercise program, because we want to make it effective, but we also want to make sure it's safe. And, work alongside Dr. Phil is definitely making this the transition a lot easier with that. But yeah, it just allows me to create a program that's both safe and effective for that person.
Yeah, no, that's really, really important to know, because that is part of the fear of starting something. Is it going to be safe for me? Especially that thought is much more prevalent in people who do have some active pain going on, whether they have some arthritis in their knees or some chronic back pain from an injury they suffered when they were 20, and here they are 20 some odd years later, and it's still kind of hanging around whenever they do a little bit more physical activity in their day. So knowing that there's going to be a very measurable and safe way to get them going on that exercise program is just another piece of the puzzle to calm some of those hesitancies.
Yeah, some of the fears that
Some of the fears
hesitancies they might have. Yeah,
yeah,
exactly.
that they might have. Yeah.
Yeah, because like I said, taking that first step, it like, I mean, for somebody like me that loves exercise, it's so easy. Oh yeah, like exercise, no problem. But like for somebody that's just getting off the couch and like they're just trying to just be healthy, like that's a really hard step. I always tell people it's the hardest step is to like actually get to the gym.
Yeah.
And start working out.
Yeah, and then once you get there and have the support of that one-on-one personal training, it calms those fears very, very quickly. And even with just a little bit of movement, a lot of these folks are going to see a lot more improvement in just day to day when they get some of that movement and get it the right way for them, which is huge.
Yeah. The key is getting to the parking lot of the gym.
That's right. Yeah. And getting out and getting through the front door.
Getting out of the car and then opening the gym door and actually walking it and not turning back.
Right.
Right. And just building that skeletal muscle. I mean, the biggest storage for our glucose is our skeletal muscle. That's where we want it to go. We want some to remain in the bloodstream so we can use it for energy, and some to go to this muscle. We don't want it going to the liver. We don't want it going to fat cells. That's when it becomes toxic. That's when we develop problems. So just having more volume of muscle helps to balance your blood sugar. So that's, another reason why this is so important.
Sure. And I'm sure you've probably heard this before, Valerie. Steve, all of us have probably heard this. You mentioned increasing physical activity and exercise and stuff like that. And I oftentimes get I take walks with my dog like 3 or 4 times a week, or I have a very active job where I'm on my feet a lot during the day. And that's where kind of the knowledge of someone like Evan comes into play here, because those things aren't going to build more muscle. If you haven't done any of that and you're like completely sedentary and you start walking 3 times a week, you're going to get stronger, but only to a point. Right. And then we switch over to a maintenance phase and a more endurance phase where those muscles aren't going to get stronger from moving your body weight around anymore. So we need that graded strength training to actually build that bigger skeletal muscle in those bigger muscle groups that also like our quads, the front of our thighs, our glutes, our buttock muscles, the biggest muscle groups in our body that are also the most functional groups to train, Steve, you raised your virtual hand.
Yeah.
Go for it.
I wasn't sure what else to do, but so, one of my favorite kind of problems I like to work through with my patients is to explain them exactly, how many calories are in things, right? So I would hold up a pack of Oreo cookies, just 2 Oreo cookies, and explain to my patients that 2 Oreo cookies have about 100 calories. How far do you think you need to walk to burn off 100 calories? And people would say, I don't know, 100 yards, 50 yards. They have no idea, but it's about a mile. It's about a mile. And then I would ask them, how far do you think you have to move in order to burn off a pound of body fat? And people would come up with the most ridiculous numbers. They'd say, I don't know, 2 miles, 3 miles. I'm like, no, it's more like 35 miles. You have to move so far to burn off calories that, and then you have to think about it in terms of like caloric density, right? So if you're looking at an Oreo cookie, that's highly dense, calories with virtually no nutrition in it. But if you take the equivalent calories of, say, a boxed salad, right? You could eat basically a garbage bucket full of a leafy green salad and it won't have as many calories in it as a Kit Kat bar. But it's nutrient dense, high nutrition value, but low calories. Right. And, that is one of the biggest misconceptions that people have. People mostly don't understand how many calories are taken in, and that is one of the big things, or how many, the bigger thing is like how many calories they're burning off. Right. People get on a treadmill and they'll walk for half an hour and be like, oh, boy, that was good. You only burn like 75 calories.
Right.
Walking on that treadmill for that long.
Yeah.
So a lot of it is, getting people to understand, exactly how many calories that are in there. And Valerie, that's one question I had for you. Like, how do you work with your patients in their calorie intake and macronutrient distribution? Like, what's your approach to that?
So to be honest, I hate counting calories. I think that initially I'll have them track their food just so that they get an idea of how far off they are, sort of thing. But not for me to say, oh, you went over your calorie intake, let's slap you on the wrist, sort of thing, because it really is, like you said, about nutrient density. Like, how many micronutrients are you getting in? And of course, the right balance of macronutrients with that meal versus how many calories. So were those calories worth it? Essentially, are they working for you or are they working against you? And I think that's what I try to focus for. I really try to set a mindset of abundance when I'm working with any client. Like, what can you eat? What are the things that you can and should eat that are satiating, that you're going to feel satisfied and full after eating, and that are not going to put you over that point where your blood sugar is then spiked and you're kind of wrecked for the rest of the day.
Right.
And so we focus on that first. And when people start to take in those foods that are really nutrient dense, their calories drop dramatically. And so we focus on there first. And if people just can't hit that, and they're still, even though they're eating healthy foods, they're eating too much, which rarely happens. When we're eating healthy foods, generally we're full. Fiber has a mechanical stretch on the stomach, right? Protein makes us feel full. It releases leptin, which is the hormone that signals to our brain that we are full. Carbohydrates don't do that. They inhibit actually that hormone from being released. And so we never get that signal to our brain that we're full. And so when we start to focus on protein, healthy fats as our primary source of food, clean products too, the calories come down dramatically and the weight comes off.
Have you ever heard of the term called vanishing caloric density?
No.
So it's a term I discovered in the basically the junk food and snack food industry, and it's the idea of you could have like a cheese puff or a Dorito or a potato chip, and when you eat it, it's crunchy and it satisfies that kind of mechanical need. It's salty and it's savory, and you chew it up and you swallow it down, and your gut doesn't even recognize that you ate anything because it takes up no space. So it's vanishing caloric density. So it's all these calories you can plow in, and your gut will have no idea that you ate that much food.
And that's really sadly what the food industry wants, because they want to, of course, sell their products. It's about the bottom line. And
make more money that way.
You never feel full,
money,
but you've just consumed all those calories.
Right.
Yeah.
That's why they say bet you can't eat just one. Right.
Yeah. And
it's not a dare. It's physiologically you can't.
Right. It's true. And right. And so they also, some companies will actually strip the protein out of the food, sell it as a different product because it's an expensive product, right? So create a protein powder out of it or something like that, take it out of the food that's, let's just say a cereal, something like that, so that people consume more of that cereal and buy their secondary product. That's an expensive product, right? So it's kind of scary when you go into the, politics of food, but we're here to kind of support you in making the right choices that make you feel satisfied, right? That make it easy for you, and that you no longer have that desire to go down the cereal aisle. Just stay out of it, right? And go to the whole food section, the produce and the meat and the dairy, to a certain extent, depending on who you are with the dairy. But go to those places in the grocery store that you're going to find foods that were made in nature and that are actually going to serve your body well.
And then on top of that, now we have good fuel in our body, so we can fuel it. And some of those things are if we're eating a lot of processed foods. Again, this is my area of expertise, but I've heard you talk about this before, Valerie. But that can improve some joint health and some just general inflammation in the body, which can be contributing to pain that might inhibit them from being able to do the work that Evan needs to be doing, and with them and all that as well.
There's a pretty clear correlation of high blood sugar and kind of inflammatory protein biomarkers in the body. So that's a pretty clear relationship. And high blood sugar really just does a lot of damage to the microvascular structure of your body. Healing gets harder.
healing gets harder. And that's something that I see, I see a lot too. And so it's kind of multifactorial, right? So for sort of my portion of the program, working with more of the pain that someone might be dealing with that's preventing them from getting to that intensity of exercise they need to make more of those more significant changes in those blood sugar levels and decreasing that insulin resistance. It's kind of multifactorial, right? It's interfering with healing, right? The high blood sugar, like what Steve just said, it's interfering with healing. They might have some higher inflammatory markers in their body because of the diet that they tend to eat, and by carrying around a little extra weight, and the ways they move or don't move, and their body compensates for that and adapts to that over time, they have more stress on certain joints that help move us around the most during the day. And all of that adds up to pain that is sometimes very, very chronic. And if those people are going to someone who isn't Steve and they're just getting that 15 minutes, they're maybe getting medication to take care of that. They're maybe getting repeat injections, which is actually damaging that tissue more than it's helping after a certain point, right? I'm not saying no one should ever get a cortisone injection ever. I think if you need that to get over the hump a little bit, that's perfectly fine. But when we couple that with some physical rehab, some good working on the imbalances that are putting more stress on that joint or that area of the body, which is the reason they're actually having the pain. I like to tell people that just because you have arthritis does not automatically mean you're going to have pain. A great example that I've had, I don't know how many people that I've worked with over my career who come in with knee pain. This is the best example, with knee pain. And they go, yeah, my left knee is absolutely killing me. You know, it's funny, they did x-rays on both knees, and my right knee is bone on bone. They said there's no cushion left there. And my left knee actually has some cushion, but that's the one that's killing me. So even within that, that's a small sample size, but I've had it happen enough that I think if we did a study on that, it would show, and there have been some done on this, it would show that the presence of arthritis in a joint alone does not mean the person's going to have pain.
It's we have seen plenty of people, like, you know, elderly people that get up in their 80s, and you take a look at their x-rays on their knees, and they're horrifyingly complicated with osteoarthritis, but doesn't bother them, hurts a little bit here and there.
Sure.
You know, sure. It's really kind of an interesting phenomenon, and how some people are bothered much more by that than others. And you know, it's really hard to explain why.
Yeah. And again, I think it is a multifactorial approach, because a lot of the folks that are suffering from that type 2 diabetes have all of these things going on. They've had the elevated blood sugars for really long periods of time. The diet interferes with it. So there's a lot going on, but even regardless of changing on that, because before I got involved with more of the prevention side of things in my career, when I worked in part of the field that wasn't meant for prevention, which is why I got away from it, you know, without even changing that person's weight or blood sugar or diet, we were having a positive effect. It might not have been perfect, right? Because it definitely could have been better, but we were getting people to a point where they at least didn't have to be thinking about a knee replacement in a few months. You know, they could get through life without it being debilitating. So when we can have that profound effect by getting certain stabilizing muscles moving and working a little bit better, getting their bigger muscles working better within the movements that cause that knee pain, and doing so in a very, I always say, a conservatively progressive manner, where we're moving someone along and bumping them up on almost a weekly basis, but doing so really based on their symptoms, so that we're always moving forward, but not so quickly that we're going to move ourselves backward at all from a pain perspective. That really allows them to even do things more like just walking a little bit better, or when they go up the staircase at their house, they're using those muscles more effectively. And because some of those things are so weak, just going up the stairs a couple times a day to do the laundry or go make the bed or whatever they're doing, they're actually getting those muscles a little bit stronger, right? And then to a certain point, that's when they get to a point where they can go really get something out of something like what Evan's going to be able to do with them. So that's kind of my big role in the program, is to make sure that these people don't have any hurdle that's going to hold them back from the higher level exercise that they need to have the more drastic drops in that blood sugar. And with the we're going to chat a little bit real quick here about one of the people that we're working with right now. Even with that individual, just working on those sort of foundational exercises and movement patterns to get rid of his knee pain. That combined with a walking program, along with some of those dietary changes, even before starting some of the higher level exercise that he's really working on hard right now with Evan, we already dropped his blood sugar from, what was it, Steve, about 250 plus down to below 200 consistently here for the last
Oh yeah,
few
easily.
weeks.
His blood sugar was, somewhat trending up into the 300s. And
Right.
I had him as a patient for probably the better part of a year. And so let's kind of like back up for a second. The way you diagnose diabetes, let's start there. So
Great point.
he came with a diagnosis already of diabetes or pre-diabetes because his hemoglobin A1C was running around 6. So if you have a diabetic patient that's around 6, that's on insulin or medications, usually that's pretty good. You're quite happy with like a hemoglobin level of 6. Any higher than that, if you're a person who hasn't been diagnosed with it, 6 is a pre-diabetic. And then when you start going above that, then you are considered diabetic. There's also other ways you can diagnose it if you take a random blood sugar, random figure stick blood sugar, and it's above 200, that person's got diabetes. If you do an oral glucose tolerance test, it's where you swallow a whole bunch of simple sugar, and we check your blood sugar at different intervals after that. And when your blood sugar is running up above 140, that's also considered you're also considered to be diabetic. So there's a couple different ways you can diagnose it, but mostly the way we track it now is with a hemoglobin A1C. And this patient, problems were complicated by the fact that he has some rheumatoid arthritis. So that's an autoimmune disorder affecting the joints, and it can be quite devastating if the person has a rather aggressive form of it, or if it's really kind of out of control. And I think that was hampering a lot of his physical activity.
Yep.
Not to mention his, the patient's working a lot, putting a lot of hours in, stressful home life, stressful stuff going on at work. And then, he was having trouble with his knee pain, and he wanted to get that under control, and went back to a rheumatoid arthritis physician, a rheumatologist, who provided him with, monthly corticosteroid injections inside of the knee. Sometimes they can bump up your blood sugar. Some people were more sensitive to it than others. Might see a higher elevation of it. And he was one of those guys. He's one of those guys who it really pushed him over the edge. He was getting regular steroid injections and his knees were feeling better, but wow, we could not keep his blood sugar under control. And, the first medication you usually start people on metformin, glucophage. Works by inhibiting the liver's synthesis of additional glucose. And it works well, and it's usually a first-line drug for type 2 diabetics. But his hemoglobin A1C really started going through the roof. I mean, it was starting to get up in like the 7s, 8s, 9s, and he started getting very anxious about it. So at that point, you can start making a decision about where do you go next. So there's other oral glucose lowering medications, such as the glitazones, sulfonylureas, which have their drawbacks and risk. But some of the newer blood sugar lowering medications are these kind of incretins, these chemicals that your body secretes, or it works on chemicals that your body and brain and gut secretes. And one of them is a GLP-1, and these glucagon-like peptide agonists are medications that slow basically your liver down from producing more blood sugar. And there's another class of drugs that will also increase your body's excretion of blood sugar. So basically you pee out more glucose, and they have different side effect profile than the GLP-1 receptors. So some of the GLP-1 receptor agonists have been shown to be quite good and very favorable in terms of side effect profiles, as well as lowering blood sugar and protecting against cardiovascular damage. And they've also been shown to significantly lower weight. One of the few drugs that that have come up that actually decrease people's weight. And
with this person was definitely at a point where that discussion was being had, and some of those things were put into put into place.
Absolutely.
And those things were initiated, and that's kind of the point where the entry to this program really starts to kick off a little bit, because it was,
Well, yeah, we had already talked about starting this up, and then, we're still kind of struggling with a way to figure out how to make it into one package. But I think the way we're doing it now probably works as well as we can hope for, unless we had our own clinic and building.
Right. So you were seeing those markers with that gentleman.
Yeah, and he seemed like an ideal candidate, right? So he's someone who's local here, who and I think one of the big things for patients in this kind of program is the accountability factor. And I think the accountability factor really counts for a lot, and people who are highly motivated, but they just need that kind of accountability, someone to have to check in with and make sure that you're checking off the boxes of your exercise and diet, and being brought back to the center, like, oh, it's okay, don't worry, you ate a donut, no big deal, let's get a little more exercise in, and don't worry, don't freak out over it, it's not a sin, you don't go to hell for it. But,
that accountability is super important, but so is the sort of the guidance and support of, like, what we've already talked about on this discussion of even just how to get started. So Valerie, I want to talk to you a little bit about some of the just quick initial things, like give us a few of those sort of low hanging fruit baby step things that you initiated with this person that seem to be very impactful. Because as I said, we've probably been cumulatively working with this individual for 6-7 weeks or so, and we've already seen some pretty maybe 8 weeks or so, and we've already seen some pretty significant changes. So what are some of the initial things that you worked on with this person that helped tremendously in that arena?
Sure. So this particular individual that we're talking about was, he was really trying to begin with, he was really putting a good solid effort in. He had done his research, but there were a few things that needed to be adjusted, the timing of his eating specifically, making sure that he's getting quality protein and enough protein in each meal, making sure that he is eating in a way that doesn't mess with his circadian rhythm, because he works the night shift sometimes, and that really messes people up. At night, we do not release the same hormones that help us store glucose into our muscle the same way that we do during the day. So when we eat carbohydrates at night, we have a much different effect than we do during the day. So that was a discussion that we had to have. It's just simple things. It is the accountability. I gave him a specific plan to follow through with, which he is, and he's reporting back to me. And it is a lot of that accountability, along with the tools to make sure that he's having balanced meals, and getting the right ratio of enough protein, healthy fats, and the carbohydrates that he's eating are dense and complex.
Sure.
Yeah,
and then from a movement perspective, Stephen mentioned the knee pain this individual was dealing with, and that was really holding him back from, he was telling me that even just going for like a brisk walk might not feel in the moment, but the next day he kind of paid for it, right? And then he kind of had to limp around on those legs on his long shifts overnight at work and things like that. So, we've started to overlap a little more, Evan and I, but this is kind of where Evan and I came in, of identifying where those movement patterns needed to be helped in order to decrease knee pain, so that day to day wasn't causing him knee pain. And then we could, as I mentioned, in a very conservative yet progressive way, ramp him up to a point where he's doing a graded walking program without any increases in knee pain, and starting those higher level parts of exercise as well they're going to help that even more. So that's what I was really primarily working on, is taking as much stress off those knees as collectively as possible, so that work, day-to-day life, and even a brisk walk with his family and the dog weren't going to set off any of that knee pain. And then Evan, go ahead and talk a little bit about what you've been working on thus far, and what you're getting going on with this person in particular.
Well, thanks to you, because I talked to him about a month ago, and he was saying that he was having knee issues, and that's really kind of stopped him. So he told me that he was going to work with you for a while, and now he's to the point where he doesn't have that pain. So now this week is actually his first week. So basically, kind of like what you were saying earlier about, like, how, like, I'm gonna be working more on the higher level stuff, just in terms of progressing, in terms of what he was able to do for exercise without dealing with pain. So basically my job now is to, kind of just keep reinforcing what you've been doing with him, and just like kind of take him step by step progress him the correct way, and making sure that, in terms of like, any further injuries, like I'm helping him increase his performance so he doesn't have any more injuries, and so he doesn't have to go see you anymore.
Yeah, sure.
And, this individual that we're talking about, when I was sitting down with him, he was also talking about kind of long-term that he wants to be able to do things with his kids, and like, he doesn't want to be limited by his body anymore. Cause I think and he like does winter sports too. So he wants to make sure that his body's able to do that as well. So like, the strength training is not only going to help him with, his diabetes and, limiting him from injury, but it's also going to just allow him to continue to do the stuff that he loves to do. So that's what I'm going to be doing.
Yeah, that's fantastic. And I that's where, again, just to kind of bring this all full circle, like having someone who can identify where this person's at, as Steve said, where they're at a great place to be able to fully reverse that type 2 diabetes diagnosis is super key. Having someone who's going to really tackle all of the different obstacles to that person's specific diet and nutrition plan, and then being able in the safest and most effective way possible grade that person up through their exercise and have a seamless transition from more of a rehab based exercise that then transitions more into a supportive preventative role alongside the strength training conditioning that's going to take that prevention role even further, is exactly how we sort of designed this program. And the initial idea for this program was sort of a 12-week program. And I think within right around about an 8-week time frame from the time he got started with just about all the components of the program, we're already seeing a lot of the things that we wanted to be seeing at 12 weeks with this.
Yeah. Oh, I have no doubt we're going to see a significant improvement in his blood sugar. And if we can get him, if we get him normalized, I mean, I can't explain how big of a deal that is, because once you normalize your blood sugar and, essentially reverse your type 2 diabetes, I mean, once you make the diagnosis of diabetes, it's considered a cardiovascular equivalent. So what that means is that once you achieve that diagnosis, your risk factors for heart attack are the equivalent of someone who's already had one. Right. So that's how bad diabetes is. It is basically the equivalent of having already had a heart attack.
Yeah. Wow. Yeah. So
heart disease.
Sure. So that's why catching this that much sooner is that much more important, because it can be reversed. So real excited to be working on this with all of you. And I can't thank all of you enough for spending your time to go over all this incredible information with people that might be listening. I would say to everyone out there who is listening, if this sounds like something that you could use help with, if this sounds something like your friend, family member, someone can use help with, please reach out to any of us. You can find all of our information right in the show notes or the description of this video. If you're watching on YouTube, please reach out to any one of us, all of us at the same time, however you feel most comfortable reaching out, and we can talk to you about how this program can be right for you or your loved one, because we all truly feel passionate that everything these folks are dealing with is something we can really, really help with, and in many cases fully reverse. Or if you've been given that pre-diabetes diagnosis that Steve was talking about, we can make sure it does not get to that full diabetic stage where you have the same risk of having a heart attack as someone who's already had one, which is crazy.
It's insane.
It's a crazy statistic, and it might be one of my new favorite ones to share with people who might be dealing with stuff like this. So Steve, Valerie, Evan, thank you so much for joining me tonight. I really, really appreciate it. Always love chatting with all of you anyway. So it's great to get us all together so we can all chat about how we can work together to help more people in this way. So thank you.
Yeah, I'd love to do this again.
Yes, for sure. We'll have to give some updates and maybe even do some more case studies, because I think that would be fun to have a little bit more longer form situation of what we went over at the end of the podcast here. So that might be something we definitely do again. So thank you all so much for joining me again. And everyone out there, thank you so much for listening. Please be a friend and tell a friend if you got something out of this. Reach out if you need some help. And we'll see you all back here next time on the Strength for Your Purpose podcast. Bye, everybody.
Bye, everybody.
Bye.
Bye.